Welcome. I'm so glad you're here. Today, we're going to explore a really fascinating neurological sign called chorea. And our goal, you see, isn't just to memorize facts for an exam, but to truly understand how we can approach our patients with the wisdom and, well, the compassion that they so deeply deserve.
Always remember this. It's so easy to get lost in the science, isn't it? But behind every symptom, every unusual movement, there is a person on a very difficult journey. Our real job, our true calling, is to learn how to read their story so we can offer not just treatment, but true healing.
One of the first people to describe these movements used this beautiful poetic phrase. Before we dive into the technical definition, just hold this image in your mind for a moment. Summer lightning. It so perfectly captures that fleeting, unpredictable, almost magical quality of what we're about to study. And here we have our formal definition. Chorea. It comes from the Latin word for the dance, and you can see why. It describes these brief, aimless, flowing movements. When it really affects a person's walk, it can look like a kind of dancing and prancing gait. That's exactly how this sign got its name. So, what are we actually looking for when we're with a patient? Well, it's these fluid, rapid movements that seem to just dart across the body, the face, the arms, the legs. And notice that second point. It's so important. The movements are often disguised. A patient might unconsciously try to mask a sudden jerk of their arm by turning it into what looks like a purposeful act, like smoothing their hair. It's a very subtle but very crucial clinical clue. All right, let's ground all this learning in a story. Let's meet Mr. David. He's a young man, only 38, and a husband. And notice, his wife is the one who brings him in. It's not a complaint from him, but a deep, loving concern from her. This is where our work begins, with a family in distress searching for answers. So you see these movements, you hear his wife's story. And I know, it can feel a little overwhelming. Where do you even start? How do you bring some order to all of this uncertainty? Well, the key, as it is in all good medicine, is to have a structured and thoughtful approach. This is our map. It will guide us. First, we just observe. We confirm what we're seeing. Is this really chorea? Second, we listen. The patient's story, the history, it's everything. We ask about medications, about family, about when this all began. And third, with that information, we start to build a mental framework, a list of possibilities to guide our investigation. Now, before we hunt for the why, let's just peek under the hood at the how. It all comes back to a part of the brain you know well, the basal ganglia, our great modulator of movement. When this area gets damaged, it's like the brakes on the thalamus are released. The thalamus then gets overexcited, and it, in turn, overexcites the cortex. So you see, it's a loss of brakes in the brain that results in these excessive, unwanted movements. Okay, so now we have our framework and we understand the basic mechanism. We can finally begin our search for the underlying cause. Let's start with some of the most common culprits. Always, and I mean always start with medications. It's amazing how many things we prescribe can cause chorea. Antipsychotics can lead to something called tardive dyskinesia, which you'll often see in the face. Levodopa for Parkinson's, phenytoin for seizures, even things like oral contraceptions. A thorough medication history is truly one of the most powerful diagnostic tools you have. Now, thinking of our patient, Mr. David, who's 38, this category is incredibly important. Huntington's disease is the classic cause of chorea that starts in adulthood, and it tragically combines the movement disorder with dementia. But we must always consider its mimics. And please, look at the bottom of that list, Wilson's disease. It's rare, yes, but it is treatable. We must never, ever miss a chance to diagnose it. Now, this isn't relevant for Mr. David, of course, but you will care for children in your practice. And in a child, the most common cause is something called Sydenham's chorea, which can follow a strep infection. But notice how different its course is. It usually gets better all on its own, which gives us a much more hopeful prognosis than many of the adult forms. And finally, we have this big group of miscellaneous causes. In a hospital, you'll often see chorea that's caused by a small stroke in the basal ganglia, but it can also be a sign of a sickness in the whole body, autoimmune diseases like lupus, metabolic problems like high blood sugar, or even pregnancy. It's a good reminder to see the patient as a whole person, not just a neurological problem. So we have this long list of causes, but we have to be certain that what we are seeing is chorea. Accurate observation is really the bedrock of neurology. So let's just take a moment to look at a few other things that can look a little bit like it. This table is such a wonderful tool. Let's look at myoclonus. It's much simpler.
more like a sudden shock-like jerk. Tics, on the other hand, are repetitive, stereotyped movements. And crucially, a person with a tic often feels an urge beforehand and can suppress it for a little while. Chorea is different. It's that mercurial, flowing quality, that summer lightning that truly sets it apart. Okay, let's pause for a moment and anchor this knowledge. These are the points to hold on to. First, chorea is a sign, a clue. Your work is to be the detective. Second, your best guide is the history. And these little associations, they'll help you quickly build that list of possibilities right in your mind. All right, let's try a quick case, just to test our pattern recognition. We have a 12-year-old girl, she had a sore throat a few weeks ago, and now she has chorea. What is this story whispering to you? If you thought of Sydenham's chorea, you are exactly right. The age, the history of that infection, it's the classic textbook presentation. Very well done. Okay, here's another one. An older gentleman, he's been treated for schizophrenia for a long time with an older antipsychotic, and now he has these new movements, mostly around his mouth and tongue. And this, of course, points right to tardive dyskinesia. You see how powerful the history is? In this case, just knowing the medication history practically gives us the diagnosis. Excellent work. I'll leave you with a few questions for your own reflection. Now, please don't see this as a test. See it as an invitation to go a little deeper, to really solidify your understanding and to spark your own curiosity. The answers are all right there in what we've discussed today. My goodness, we have covered a great deal of ground together. So let's just gather all the threads and summarize our journey so you can carry this knowledge forward with real confidence and clarity. Please remember these 4 things. First, learn to recognize the sign. Second, always use a structured approach. Third, see your work as a journey to understand the patient's unique story. And finally, know that by finding the cause, you open the door to the right treatment, and you bring hope to your patient. And this is the most important takeaway of all. The knowledge we gain isn't for our own sake. It is a tool, a gift, that we use in service of another human being. Let your intellect always be guided by your heart. Approach every patient, every family, like Mr. David's, with all of your skill, yes, but most importantly, with all of your compassion. Thank you for learning with me today.